Phenolsuphonephthalein. It has been objected that no artificial elimination test can equal urea estimation of kidney function because the kidney naturally eliminates urea and does not naturally eliminate other substances. The only answer to such an argument is that the wide experience of many observers has led to an almost unanimous consensus of opinion to the effect that the phenolsulfonephthalein output usually gives more accurate evidence of kidney function or impairment of function than any other test. We repeat that this refers only to surgical cases. The phenolsulfonephthalein test is notoriously inaccurate in medical cases. The test was introduced by Drs. Roundtree and Garratti. The apparatus required is a 6% solution of phenolsulfonephthalein. This is sold in 1 cc ampules. One also requires a colorimeter. The Dubosc colorimeter is much the most accurate, but its readings are unnecessarily accurate, i.e., the reading is more precise than is warranted by the test. The Dunning colorimeter, though it permits errors of 2 or 3% in the reading, is cheaper than and fully as accurate as any other for practical purposes. The Hellige colorimeter, though practically no more accurate, is more expensive. The kidney function of a healthy person known to empty his bladder is estimated as follows. 1 cc of the solution is injected into the muscle of the lumbar or gluteal region. The time of injection is noted precisely. 10 minutes later, the patient is made to urinate. If the renal function is normal, the phenolsulfonephthalein output will have just begun, and the urine, if acid, will be of an abnormally bright yellow color. The addition of a few drops of sodium hydrate solution or other alkali to this urine changes its color to a bright cerise. 1 hour later, the patient urinates again. This urine is diluted to 1 liter, and a few drops of 5% sodium hydrate solution added to it render the urine alkaline and bring out the cerise color. The urine is then poured into the ampule provided and measured in the colorimeter. At the end of a second hour, the patient urinates again, and the urine thus obtained is alkalinized and measured in the same way. It will be found that the normal kidney begins to excrete phenolsulfonephthalein within 10 minutes, eliminates at least 40% of the amount injected within 1 hour, usually 50% or more, and in the second hour, 10 or 20% more. The normal total for 2 hours is at least 50%. It is usually 60 to 70% and may rise as high as 80%. Roundtree and Garratti insist that the patient shall drink several glasses of water during the test. This has the advantage of filling the bladder with enough water to ensure the patient's ability to urinate at the end of each hour. The following precautions are to be noted in reference to pathological cases. 1. If the urine contains much pus, it will become very ropey on addition of the alkali. Therefore, the alkali should not be added until after the urine has been diluted. The dye is diluted with the urine, and the resulting ropiness does not interfere with the correct estimation. 2. Blood in the urine is a rather serious impediment to exact estimation. Nevertheless, if the urine is permitted to stand for a while before being diluted, the blood corpuscles will settle to the bottom of the glass, and the supernatant fluid may then be used with a fair degree of accuracy. 3. If the patient does not empty his bladder, it is of course necessary to catheterize. 4. If the output of phenolsulfonephthalein is much delayed, it may be found that it does not appear in the urine at all for half an hour or even an hour after injection. Even longer delay sometimes occurs, but in that case, the total output in any 1 hour is never more than a trace. In such cases, the output for the first hour is usually approximately the same as that of the succeeding hours. Most exceptionally, the kidneys delay the output of phenolsulfonephthalein as long as an hour or so, and then excrete a relatively high percentage, as much as 35% even, in the first hour, and very little in the succeeding hours. In such cases, the delay in output of phenolsulfonephthalene is not nearly so significant of bad function as the ability to concentrate the drug when it is excreted is evidence of good function. Consequently, in such instances, it is well to repeat the test if it has been done by the routine method, watching for the precise moment of excretion and measuring the first hour from that time. Phenolsulfonephthalene estimations are, of course, comparable not to percentages of urea, but to total urea, i.e., to the amount of urea excreted in grams during a certain period. Thus, we must always bear in mind that quantitative inaccuracies in the amount of urine passed, such as result, for instance, when retention of some urine in the bladder or when the ureter catheter is employed from extracatheter flow, introduce no inaccuracy in the estimation of urea percentage, but do introduce an unknown element of inaccuracy in the estimation of total urea and of phenolsulfonephthalene percentage. Thus, the urea percentage is that estimation which is the freest of all from the element of technical error. But apart from technical errors, the phenolsulfonephthalene output is more sensitive than the urea percentage. On the other hand, phenolsulfonephthalene does rather magnify the loss of kidney function, and exceptionally, the phenolsulfonephthalene output is very low, although the kidney function is seemingly little impaired. I have, for instance, reported a case of urethral stricture who entered Bellevue Hospital in acute retention. I promptly performed perineal section without a guide under ether. The next day and several times during the next few weeks, he excreted only a trace of red in 24 hours. Yet he had no untoward symptoms. He remained in the hospital for a number of months. During that time, he was twice given a spinal anesthetic, once for a Cabot resection of the urethra, once for a Chetwood operation on the neck of his bladder, and finally the resulting fistula was closed under a local anesthetic. Yet during all this time, he never showed more than 5% of phenolsulfonephthalene in 1 hour, and during the greater part of the time he passed but a trace of the drug in the first 12 hours after its injection. Footnote, he was alive and at work 2 years later. Such a low phenolsulfonephthalene output is usually prohibitive of surgical interference, but the cases cited is showing that in some instances one may disregard a low phenolsulfonephthalene output if all other signs point to a favorable general condition, and especially if the blood urea is low. Although the phenolsulfonephthalene output is expressed accurately in figures, these figures do not read the same for one case as for another. The patient is a human being, not an inanimate object. Other things must be taken into consideration as well as the phenolsulfonephthalene output. Beer has suggested that operation may be safely performed upon persons with a very low phenolsulfonephthalene output if it can be shown that the gravity of the lesion in one kidney is much more marked than that in the other. In this case, the lowered phenolsulfonephthalene from the relatively normal kidney is but a reflex phenomenon which might be safely disregarded in certain cases that appear to be otherwise in good health. I should gravely doubt my ability to apply such a rule in practice with any degree of success. Not only have I operated upon persons with extremely low phenolsulfonephthalene output, but I have seen at least one patient die of acute renal congestion immediately after operation, although the phenolsulfonephthalene before operation had been high. In this case, the high output before operation was justified by the post-mortem appearance of the kidney, but the shock of operation was too much for the patient to bear. Such exceptions in the interpretations of the phenolsulfonephthalene output will continue to occur. They are due to two factors. The test itself doubtless fails to indicate the precise general renal function in certain surgical cases, just as it does in many medical cases. But the more usual reason for its failure is that the surgeon's question is not, what is the kidney function at the present time, but rather, what will the kidney do if I operate? This question involves many elements that no single test can cover. It is a question that can only be answered out of the broad experience of the surgeon. The phenolsulfonephthalene test forms, for many of us, an essential element in this answer. A high output of the dye is most reassuring, A low output may be due to errors of technique, to disease in the kidney, or to obscure causes that we cannot understand. But in many cases of obscure surgical disease of the kidney, the marked lowering of phenolsulfonephthalein output is the only clear indication that the kidney is gravely impaired and will doubtless not withstand the shock of general anesthesia and operation. One of the chief functions of the phenolsulfonephthalein test is, therefore, to act as a danger signal. Though what has just been said suggests the peril of attempting a too precise definition, the following figures may be accepted as roughly accurate. In 1 hour after the onset of phenolsulfonephthalein excretion, following intramuscular injection, 40% or more is a normal excretion. 25% or more shows moderate impairment of function. If less than 20% is excreted in 1 hour, the impairment of function is probably very grave. A low excretion due to tuberculosis or to acute renal congestion, notably that due to the institution of catheter life in prostatics, is particularly ominous. But a chronically low output, as in the case mentioned above, is simply a sign to beware.